Museum. The first speaker is Dr. B.K. Bera. Is he here?
No.
Dr. Sanjay Ras.
Yeah. Sanjay.
Okay. So he will talk on management of congenital hyperextension of knee in children.
Sir, which one is yours? Sanjay Kumar Das or Kate?
जब हो गया हम लोग जाएंगे. Okay, good afternoon, respected chairpersons, distinguished delegates, my seniors and friends. I am going to present a rare topic which few of our surgeons come across. That is management of congenital hyperextension of the knee in children below 3 years. This is the upcoming issue of AIMS Bhubaneswar where I am working. It's about 1.5 years old. Already second batch MBA students have been admitted. So it has got so many names. Congenital hyperextension of the knee, congenital dislocation of the knee, congenital chain recurvatum, backward bending of the knee, congenital lateral dislocation of the patella, which is a combination of knowledge, and sometimes we diagnose congenital lateral dislocation patella where there will be hyperextension. Prevalence incidence is 1 to 2 per 1 lakh live birth. Unilateral 60%, bilateral 40%, male female ratio is 1 to 1. History. An uncommon condition, first described by Chatlin in 1822, reported by Board in 1834, and quoted by Ferguson in 1961. Generally associated with other congenital anomalies, and equal distribution in both sides, as I told you. What is the cause of this congenital hyperextension? There are two types of cause. One is intrinsic cause, another is extrinsic cause. Intrinsic cause is the genetic abnormalities, 1891, and Behmans, 1900, postulated an abnormal genetic predisposition. Extrinsic causes include abnormal fetal position, primary contracture of the quadriceps tendon, that is Middleton in 1935, described this. Traumatic dislocation during pasteurization, Ferguson in 1961 described this. Fetal molding due to oligohydramnios, quadriceps shortening, postlateral quadriceps contracture, and this is quadriceps shortening. Then abnormal hypoplasia or elongation of the ACL. If the ACL is elongated, then you will get a instability and there is chance of dislocation. Predisposing factors include primary, breech delivery, Larsen syndrome, Down syndrome, congenital ligament complexity, nail patellar syndrome. Common associated anomalies are where you come across these cases are DCT, DDH, arthrogyposis multiplex congenita, spina bifida, congenital vertical talus. So these may come with so many other abnormalities associated with that. There are three types of congenital hyperextension name are classified. Grade 1, you have to find only congenital hyperextension, nothing else. Grade 2 is the congenital hyperextension associated with anterior subluxation of the tibia on the femur. So you will find that you can see the X-ray line on the right side. You can see here there is little subluxation here. When you see this, there is complete dislocation you see here. So coming to the second grade, there is congenital hyperextension with anterior subluxation of the tibia on the femur, and grade 3 is the congenital hyperextension with anterior dislocation of the tibia on the femur. So there are three grades we have. Treatment options. There are two types of treatment: conservative treatment and surgical treatment. Conservative treatment commences at birth. Immediately after birth, we start the treatment. We have been delayed within a week. You have to start the treatment. Gentle manipulation with traction and flexion of the knee. It is not that we will bend the knee. You have to give a traction by body, hands together holding. Then you try movement. That's the point to remember here. You don't bend immediately. There may be a chance of fracture or there may be a physical injury. So first you give traction. So by giving traction, you are stretching the quadriceps. That point we keep in mind. Then serial testing with maximum possible flexion as you get it. Followed by public harness, keen traction, splinting, spontaneous reduction. So what is this spontaneous reduction I mentioned here? I want to mention here. There will be a reduction automatically after 1 or 2 plaster. I have been in my series. I saw that mother is very happy. He's telling that, sir, my child's knee has been corrected automatically. Then I saw in examine there is friction also, and is much better than what was before, and that is called spontaneous reduction, which has been mentioned in the literature also. Next, coming to treatment of operative management. There are three types of operation done for this congenital hyperextension knee. That is, first is the percutaneous quadriceps recession, PQR we call it. Then percutaneous needle tenotomy, PNT we call it. Then VUI quadriceps plasty, which everybody, all of us know, and we are doing in our orthopedic practice. Now we are coming, focusing on VUI quadriceps plasty because this series which I have done is only by VUI quadriceps plasty. But the advantage in this VUI quadriceps plasty is more successful in achieving and maintaining reduction in severe and resistance cases of deformity. And the other one is the all grade 3 cases. I to grade 3 means where there is a dislocation with hyperextension. Lot of disadvantages are also there in this VUI quadriceps plasty: wound breakdown, infection, blood loss, long incision with scarring, abrasion, knee stiffness. Now the surgical step of VUI quadriceps plasty, I will go quickly because all of you are very much aware of that and practicing. Long anterolateral incision, central portion of the quadriceps tendon inside in the fashion of to allow VUI advancement. IT band is released. This point, remember, IT band has to cut and release. If possible, a piece of IT band may be taken out. Anterior capsule of the knee divided transversely up to collateral ligament. And quadriceps mobilized, knee reduced and flexed to 90 degrees. So on the table, you must achieve 90 degree of flexion. The lengthen quadriceps and resuture with 50 degree of flexion. Maximum 50 to 60 degree of flexion you have to stitch. Don't stitch the quadriceps in flexion what you achieve, because if you stitch that, there will be a quadriceps slack and the operation will be a failure. So AK thrust was applied in 45 degree knee flexion, not 90 degree, 45 to 60 degree you have to apply the thrust. Plaster change on 3 days, on third day and kept for 4 weeks. Slings and physiotherapies are given once. After 1 month you remove the plaster. Without any delay you start the physiotherapy or you land up in stiffness. Best result when the knee joint is operated and reduced by the age of 2 years. What are the complications of VUI quadriceps plasty? The complications are angulated grey-stick fracture, proximal tibia if you apply any force, proper knee deformity, slight persistent and anterior subluxation may be there on the tibia or the femur. Recurrence of dislocation, even if you do the surgery, there is a chance of recurrence of dislocation. Premature closure of the proximal part of the tibial epiphysis. If a force is applied, the epiphysis growth is reduced or the damage, and there is a premature closure which will end up in shortening of the tibia. Then geniculum and extension lab up to 30 degree you may get. Treatment guideline. Well, how you decide the treatment? If you get a case, how you decide the line of treatment? Grade 1, as I told you, grade 1 is only hyperextension. There is no subluxation or dislocation. You do serial casting and the result will be successful and you will achieve the knee flexion. Grade 2 is a dilemma. 2 ways you can go for conservative or you can go for operative. How you decide? 4 to 5 casts on weekly interval attempted. If range of flexion increases more than 90, after 5 clusters the range of flexion is 90 degree or more, then go for serial casting, that is conservative line of treatment. If after 4 to 5 clusters weekly interval, the range of flexion is not improving and less than 90, then you go for surgery. That is any of the 3 surgeries. Grade 3 cases, that is where there is dislocation and that is a congenital dislocation of the knee, then surgical management is the direct treatment which can be done after 2-3 months generally. Now this series in my series which I have done in Mithar when I was there. So failure of response to conservative management, we have taken out for surgeries, cases directly reported after 1 year, associated with atrophy multiplex congenita. As you know, it is very difficult to treat any deformity in AGMC. Cases were selected for surgery irrespective of the radiological grading. Case profile, we have conducted 8 operations, bilateral 5, unilateral 3, age 1 to 3 years, average 1.5 years, sex ratio male 3, female 5. Conservative serial casting we have done in 3 cases where you got the result, that is knee flexion we achieved, and operative VUI quadriceps plasty we have done 5 cases. We have not tried with any PNT, that is percutaneous tenotomy by needle. Now associated anomalies. What are the associated anomalies? You can see the figures here how the associated anomalies are there. CTB you find here with congenital hyperextension and CTB, this is also fine. And so many other findings. So DDH was there in 2 cases and clubfoot in 3 cases and AGMC with DDH and so many other cases. Now case series, conservative management. How the conservative management was helping, you can see here. This was the condition and after plaster you can see you have achieved 90 degree plaster, 90 degree knee flexion within. This is the third plaster, 90 degrees. This is the initial fast plaster after application of the color dilation, and you find that in on third plaster we achieve 90 degree. Now another conservative case you can see here, complete hyperextension of the both knees and you find you have just this is immediately after the plaster, and that is showing the some amount of flexion is achieved. Now we are coming to the surgical procedure. In multiple deformities, knee corrected first to relax soleus and gastrocnemius. If there is multiple deformity, foot is there and knee is there, so you have to relax the gastrocnemius and soleus gastrocnemius by doing a knee release first by reducing the dislocation part, so that we get relaxed soleus and gastrocnemius. Suppose in this case, if you are tackle first the foot, then you are wrong because the muscles are tight, the gastrocnemius and gastrocnemius and soleus. So you first reduce the knee, then it will be corrected. Now outlines of surgical procedures showing the grade 1 and grade 2 radiographic findings. You can see here the grade 1 and grade 2 radiographic findings here. This is the dislocation, that is grade 3, you can see here. See this, completely dislocated. This is tibia and this is the femur, completely out from the joint. And this is subluxation, that is grade 2. This is grade 2, this is grade 3. And this is a operation showing quadriceps lengthening and anterior capsulectomy. Mobilization of the quadriceps and the collateral ligament is done during the operation. And we find in the surgical table, that is fibrous replacement of the quadriceps. Lateral portion of the quadriceps was characteristically affected. Lateral placement of the patella in 3 cases. I told you there is lateral dislocation of the patella valid otherwise. So there is lateral displacement we saw in 3 cases. But once you do the quadriceps plasty, the patella comes back and the collateral anteriorly directed in some cases. Post-operative protocol, long leg cast done with knee at 50 to 60 degree of flexion. Stitches removed after 3 weeks. Long leg brace applied with intermittent therapy. Physiotherapy has a very important role. Cardiac stimulation, the bursatus muscles, gentle stretching exercises, active strengthening exercises, and quadriceps strengthening exercises are very important in this case. Now this is the case number 2. Before and after the surgery, you can see just on the table. Before operation, this is the surgery we did it, quadriceps plasty, stitches given and plaster applied. Now results we are divided in 3 types, that is good, fair, and poor. Good is normal looking knee, full range of motion. No quadriceps lag, no quadriceps lag. That is the good variety. That is normal looking knee, full range of motion, no quadriceps lag. Fair you call it when there is normal looking knee, terminal restriction of the flexion and quadriceps lag at least last 15 to 20 degree. Poor is that persistent recurrent pattern persists and less than 90 degree of flexion possible, marked quadriceps lag and painful range of motion with stiffness. Study result, good, we have got good results in 8 limbs, fair in 4 limbs, poor in 1 limb. Now complications are there also, we had come across after these surgeries we did here. There is quadriceps lag in 5 limbs, limitation of knee flexion in 5 limbs, skin adherence anteriorly, that is a very important thing that every time you give a big scar anteriorly over the thigh and that arrests and that causes the stiffness, and hypertrophy of the scar, as I told you just now, hypertrophy of the scar. Now after stitch removal, you see the movement, the flexion of the knees up to 90 degrees we have achieved it here. And after 6 months follow-up, after a course of physiotherapy and exercises, you find that the knee is flexed sufficiently, and this will continue more. This is 2 years follow-up. This is the same case which I was showing previously, and this is the second operation case which I show you. This is another case where you find the same surgical procedure we have done. Quadriceps plasty we have done here. This is quadriceps plasty. You find extension here and some foot action also. Now conclusion. Grade 1 cases, best result by serial casting. Grade 1, if there is no dislocation, only quadriceps contracture, you try with knee flexion, you get best result. Early surgical intervention should be adopted as soon as the patient failed to respond to conservative treatment after 4 to 5 serial casting. You do 4 to 5 serial casting. If there is no yielding of the knee flexion, you don't find any knee flexion improvement, less than 90, then go decide for surgery. Grade 3 cases, VY quadriceps plasty and anterior capsulectomy needed under simple surgical procedure. Quadriceps lag, frequent complications. So that has to be kept in mind that after this operation, most cases go to quadriceps lag. But 5 to 10 degree quadriceps lag is acceptable. As they grow, this develops, the power of quadriceps develop, and there is a good result. But if more than 15, be careful for that. He may have difficulty in walking. So you have to give a strengthening exercise for quadriceps, electrical stimulation, and give more stress and rehabilitation. That is physiotherapy. Thank you. Thank you very much.
Any questions to the speaker?
If there is DDH you mentioned, so when you will take care of the DDH at the same time, later or before?
No, first, if there is hip, knee, ankle and foot involvement, first you have to tackle the knee. Because if you are tackling the knee, then you are also easy to go for DDH. Because DDH you cannot take off so easily. DDH, can you take the DDH operation after 1 month or 2 months? Manipulation. Manipulation can be done. Manipulation, I am thinking, he is asking for surgical procedure. Manipulation, conservative, we can go for DDH, no problem. But surgical procedure, you should first do the knee, then you go for hip. And last you go for the CTV.
Another one is after the surgery, you maintain the position, using K-wire like these things, or only on faster?
Only on posture. Because that will damage the pieces. You know that there is a brace called public harness, which will keep inflection of the knee as well as hip. So that will help.
One thing can I add?
Yeah.
Instead of DY plastic, if you do Z plastic,
Uh,
and the horizontal limb will come the lateral side at the low level, so it can serve both the purposes.
both these are the things.
Means you are interested on iliotibial band. From the lateral side,
No, IT band we are releasing. We are cutting the IT band.
it doesn't matter.
We have to release it.
How does it matter?
There is some amount of tightness.
That I'm telling you, can get it relieved. And I have got the experience with the, I think 15 days back I have operated.
Is that okay?
Yes.
What you did?
Yes, I did Z plastic. He has done Z plastic. DY plastic, I did Z plastic. And I got correction of means I have applied the plaster. He has got bilateral. And one side it was yielding. So therefore I conservative management.
One side conservative, one side operative. Ah, that can be done. Now we have come across one case like that. We showed there.
Any other question? So one question from my side.
Yeah.
When to start manipulation and seal casting after birth?
Within 7 days.
Within 7 days.
Yeah.
Okay, fine.
Because as early as you start, then the concepts will yield you.
That will be given in 7 days.
Ah, yeah, absolutely.
Because it is a customary, because the skin is not.
No. Nowadays you give that support, you can give.
No.
Ah, yes. But those concepts have gone already. That's that.
No problem.
Those
You think of our biomechanical study tells that in case of CTV, it is the culprit in general which causes and perpetuates all types of deformities.
no, that is my point is to say that there is no harm if you do the plaster within 7
The
days.
skin is tiny.
Those days are gone when you are not doing plaster of 1 month. Yes, I do gentle only. Otherwise, if you may damage. Try only manipulation. No, only manipulation.
It is not giving any harm.
No, for this hyperextension knee, if you do only manipulation, again it will go back like spring.
We are keeping it like that.
You can keep inflection.
So you start the plaster from the first week?
First week, yes.
I think
Club food nowadays, everybody, Panditi also says that you start on the day 2 or day 3. And you know that we are not giving cotton nowadays, we are giving the soft roll, very soft. Only. No, cotton is definitely less than the soft roll. Soft roll is better.
Okay. Thank you, Dr. Sanjay.
Thank you.
The next talk is by Dr. Shakti Prasad on the management of hip in cerebral palsy.
दिया उधर से कहाँ गया तुम्हारा? हाँ, है ना, अभी शुरू से दिया। 42 days में Respected Chairman sir, co-chairman sir and friends. Okay. कौन का जरा? हाँ, वही चल. Hip joint in cerebral palsy is a cause of concern for the parents, the caregivers, doctors, the therapists who are involved, because the hip joint itself slowly subluxes and dislocates in course of time. So my paper is how to manage this hip joint in cerebral palsy patients. So as all of you know, cerebral palsy is a non-progressive regional brain which occurs due to some multiple causes, and it leads to problems in their posture and also motion. So the cerebral cortex basically involved in that mostly. The other parts of the brain may be involved, cerebellum, other part medulla, others may be involved. There are so many classifications as in the ectopographical, previously hemiplegia, paraplegia, diplegia. but now the recent one is gross motor functional classification system. This gross motor functional classification system divided into 5 grades. Grade 1 is the child is completely independent, and grade 5 is completely dependent with one attendant also. All units attendant with the wheelchair also for his mobilization. So these are the groups, bedridden patients mostly. They either they do not walk or they lie in the bed. These are grade 3, 4 and 5. Grade 1, 2 are mobile. So literature shows that in the many papers, pain in the hip has been reported into 40 to 70% of the spastic dislocated hip patients. So naturally the child will, after the time erosion, they will go on crying due to the pain, because they cannot express themselves and they only cry in the pain. So that it has been reported that pain is the most important cause of concern. So our medical management includes, our main aim is to, in cerebral palsy, is to manage the spasticity, because if you do not manage the spasticity, then it will lead to contractures. Contractures will go for scoliosis, hip dislocations, other problems will slowly come. So our main first area of management is spasticity management. So non-surgical management for that is physical therapy and spastic drugs like tizanidine, baclofen, or botulinum toxin and casting. So it has been studied that hip deformity deteriorates the functional status of the cerebral palsy. If somebody has any function also, if somebody is sitting also, the hip deformity prevents his sitting posture. So functional status is prevented. So sometimes those who are walkers also, those who walk, they also present with the internal hip rotation gait. So that is made due to the hip femoral anteversion, hip flexor tightness, hip rotatory imbalance, and adductor and hamstring tightness. So what are the cerebral palsy hip problems? Basically, there is adductor and flexor contraction of the hip joint, and medial hamstrings contraction of the knee joint, coxa valga, and excessive femoral anteversion, which ultimately leads to subluxation and dislocation. So complications of hip dislocation which are studied are poor sitting balance and pain, pelvic obliquity, poor perineal care, decubitus ulcer, arthritis, scoliosis, and sometimes patients are reported by forced therapies, suppose doing forced abduction of the hip joint, leading to subtrochanteric fractures or femur fractures. It has been studied that unilateral hip dislocation sometimes goes or complication arises as a pelvic obliquity and scoliosis. Some of the unusual hip problems also will be found in that windswept deformity, means one side is adducted, other side abducted, depending upon the which muscles are contracted. Habitual anterior dislocation and capital femoral epiphyseal separation has also been reported in the cerebral palsy hip joints. Mostly it has been seen that these children, they are malnutrited, they suffer from scurvy, rickets, so there is leads to capital femoral epiphyseal separation. This should not be confused with slipped capital femoral epiphysis. So proximal femoral geometry has been studied in data by J. Rabin et al., and they have found out that increased femoral neck anteversion and increased nape sac angle lead to displacement of the hip joint and ultimately leading to deformity of the head, and that these problems are directly related to the severity of the GMFCS or gross motor functional classification system. Morphology of the acetabulum studied also, they have found out that there is a superior channel-like bony deformity of the acetabulum, and that through that trough, the head of the femur goes up and down with a 25-degree anterior and posterior sector, and that is always unidirectional, and they have studied that posterolateral deficiency is there with the acetabulum. The recent paper, Sunekar has studied this hip dislocation is found in GMFCS 4 or 5, and in these cases they have found out there is always increased tone of the adductors and flexors, there is weakness of the abductors and extensors, and there is change in the proximal femoral and acetabular morphology changes. So all these have been combined now, and it has been found, recent paper, that hip dislocation occurs due to these following criteria. So again, 2006 it has been studied by Su et al. The hip displacement depends upon the GMFCS 5. So our area patients are, the hip dislocation patients are grade 3, 4 or 5, or 5 is more maximum, then 4, then 3. So this is the same study. So these are the radiological, how we assess these patients. from clinical assessment and as well as radiological. Radiological assessment is the most important thing. So we studied acetabular index, C angle of Weiberg, neck shaft angle, shaft angle, and Reimer's migration percentage. This one, Reimer's migration percentage is most important, who shows us how much dislocated. So this is the Hilgen's line, this is the Perkins line. So how much head is going out, it depends upon that. So a percentage can be calculated. More than 33% means, more than 33% out means it is going to subluxate, then it is going to dislocate. So that is the most important area. This is the most important radiological finding to why this migration percent importance I am going to speak now. So because we can because nowadays we should not everything now we are interested for the prevention. So for prevention, migration percentage study is important, because nowadays and in adult, in outcomes, this is another Melbourne cerebral palsy hip classification system for the outcome, any treatment outcome like Perthes Stulberg classification outcome measure. Similarly also there are outcome measures also studied by these methods. So now why prevention surveillance is most important, because if we can catch them early, so they will not go for dislocation or severe subluxation or dislocation, which will go for major surgeries. We can avoid major surgery. So surveillance program has started in all the Western countries. We are also in the process in our hospital also. We are doing similarly. Any patient of grade 3, 4, 5, we are going for a surveillance program. Surveillance means doing only one X-ray once in a year. Both the hips, one X-ray. So it has been studied. What is the aim of the hip surveillance? You can catch them early, treat them early, so that there will be no dislocation. Because in this type of children, dislocation surgery is a very major surgery and with a lot of complications also. So there is a need of hip X-ray yearly once to check their hips. Those who are means grade 3, 4, 5. So it has been studied. Does hip surveillance work? They are detailed studied. Hip surveillance works in cases of cerebral palsy, and they all the authors, they have detected early, treated them early, and they have found out the result is good. Means if migration percentage is 33% or more, if acetabular index more than 30 degrees, then they has to be prevented by the minimum surgery like adductor surgery or iliopsoas surgery. Releasing these surgeries also, this hip dislocation can be prevented. So these are the surgeries. Any stage we can soft tissue release, varus tissue osteotomy with SALF, with DEGA, with carrier osteotomy, with pelvic osteotomy, or combination procedures. Or sometimes if children come with adult age with all the complication problem, then femoral head resection and Mackell procedure is femoral head resection with subtrochanteric valgus osteotomy or arthrodesis or THR. All this can be done in any stage, depending upon the stages of the either subluxation or dislocation. So surgical options are many. Some soft tissue lengthening, some proximal femoral osteotomy like varus tissue osteotomy, some have described pelvic osteotomy as the procedure. But recent is combined method has to be done to get the good results. So literature shows that like the other hip, what is the problem to other hip? If during doing suppose one side hip is dislocated, we are doing some surgery, then other side is subluxating. Then if there is contracture, it has to be released. Otherwise, there will be chance of subluxation or dislocation of that side. So best option I studied for the resection procedure, proximal femoral resection arthroplasty, or Mackell procedure, or proximal femoral interposition arthroplasty. Proximal femoral interposition arthroplasty has been studied to best, because after the head resection, so they have put a humeral head prosthesis, which gives a good results. So recent literature is combined procedure. Combined procedure in dislocation of hip is gives us the good outcome, and long-term results are good. So keeping this in mind, we have treated 28 dislocated hips, 24 children, all are grade 3, 4, 5, and we have followed up to 2 to 8 years. So assessment as usual, what is the age, how much the distribution, hemiplegia, diplegia, quadriplegia, what is the functional status of the patients, so which side is involved. So these are all for record purpose necessary. So what is the surgical step? It's a single stage open reduction which combines release of the adductors, soleus and rectus, open reduction and capsulorrhaphy, varus derotation osteotomy, and pericapsular style types of self-augmentation. So this is the combined procedures, one medial incision, another is anterior incision. So these are the surgical steps. So we found that the functional improvement, there is no pain and discomfort, better sitting balance and better general and perineal care. Clinical results, abduction is good, pain improved, and GMFC is also one grade improved in grade 5 to grade 4. Radiology results, acetabular index, C angle, Weiberg, neck shaft angle, everything increases. And Raymer's migration percentage, because I have only considered dislocated patient, I have not presenting any subluxated patient. So dislocation 100% outside Raymer's. So it has come inside and 10.4% it has reduced to it. So Melbourne hip classification system, the outcome measure, some improvement in the hip also in the from 2018. So all are dislocated grade 5, all up grade 1, 2 and 3. So no infection, no anemia, no abdominal necrosis, one subluxation after 4 years of follow-up, one subtrochanteric fracture during the therapy. So this is a case which presented with a girl of 7 years, presented with a subluxation of hip, a dislocation of the hip joint. So we have reduced, done the combined procedure, and this is the result after a follow-up of 2 years. This is another case.
Dr. Sanjay, please
3
conclude.
years. Okay, sir. This is a bilateral case. So aim is early identification, regular screening by X-ray, prevention of subluxation, dislocation. If dislocation, then combined procedure has to be done. Thank you very much. Thank you, sir.
Any questions to Dr. Sanjay?
Dr.
Shakti, sorry. Dr. Shakti.
How this adduction osteotomy, subtrochanteric adduction osteotomy helps?
Subtrochanteric osteotomy.
Varus osteotomy.
Suppose it is subluxating, then a varus osteotomy puts the head inside the acetabulum.
Why it is subluxating? Because there is imbalance between the muscles.
Adductor and flexor muscle, adductors and iliopsoas
Are,
tight.
tight.
Yes.
So if you do more adduction, the abduction which was not able to abduct. Now how can you abduct from adductor position to abduction position?
I couldn't follow.
Because the adductor was tight.
Tight.
The abductor was not able to abduct it properly.
Yes, sir.
Now you have further adducted.
Mm-hmm.
So you are going to give more strain to the abductor.
Mm-hmm.
No.
Once the hip is reduced,
Reduced.
the axis will increase.
Once the
How it increases?
Anatomy, so he'll do.
He is not, it is not completely dislocated, no?
No, it was complete. He has taken only the dislocated.
only dislocated patients.
No subluxated case.
So
Only
once,
dislocated.
once you further abduct, you see, it is not the one-day procedure.
Mhm.
It has taken years together.
Yes.
So by the time the adductor is more contracted,
Hmm.
it's powerful,
Hmm.
and the abductor is weak.
No, he'll do a adductor tenotomy.
We will do a soft tissue procedure first,
Adductor tenotomy.
followed by varus osteotomy.
Taken all three muscles.
All three muscles. Even some cases we will do first, even with subluxating, if only migration percent 33% become 35%, then we will do only soft tissue surgery, only adductor and iliopsoas tenotomy. No bony surgery.
Yes, because if you keep in that position also, abductor can work, he can work.
Yes.
But,
Yes. If this is more than or dislocated, then other procedures can be done.
it will
What we are
not
discussing.
sugar, no? Because you have done adductor tenotomy.
That's why we are telling surveillance is important. Early cases has to be detected and early soft tissue surgery has to be done.
And more you have, once you do adduction,
Hmm.
softening will be done.
Yes.
And softening will perpetuate adduction.
Yes. We will do the. We will maintain it.
See, it is not a, it is thinking procedure.
Yes.
Any experience with the botulinum?
Botulinum given in other muscles, in hamstrings and gastrocolius, but I have no experience in adductors, but I have given phenol to the adductors, and results are also good in phenol injections.
Suppose the patient is walking
Hmm.
with bilateral dislocation. Though it is not a
Hmm.
normal walk, it is a cerebral palsy, difficult walking. Whether you will go for surgery or not.
The first thing is cerebral palsy. If patient who will have bilateral dislocations, they are bedridden patients. They are not workers. First thing. They are, whatever cases we have seen, nobody is a worker having a dislocation. Usually dislocation in 3, 4, 5. 5 is maximum. There are bedridden patients. Only their dislocation has to be prevented or for the sake of the pain, because head is outside and degenerated and it is painful. Sitting.
He'll sit
Ah.
after this.
So for this, so there cannot be any bilateral dislocation patient. Not even a bilateral dislocation in a worker has not been reported. We have not also come across this such type of cases.
Thank you, Dr. Shakti.
Thank you, sir.
The next talk is by Dr. Jagannath Sahu on the role of biomechanics in orthopedics.
Respected chairpersons, audience, dignitaries in the audience, they will give comment and we will interact. Because everywhere, wherever there is presentation of orthopedic problems, usually people tell on biomechanics. So therefore, I thought that if it is possible that we can imbibe something in the young generation, what is after biomechanics, is it helpful to orthopedician or not? Which one? This lower one, no? Yeah, okay. In fact, biological science is a science of uncertainty because the penicillin is reacting to one person, not reacting to other person, though both are human beings. But the mechanical properties involved in the mechanism and function of the biological tissue almost remain constant. What is it? The mechanical base of biological system, the application of mechanical laws to living structures, the study of the structure and function of the biological system by means of the methods of mechanics. The science concurred with the internal and external forces acting on the human body and the effects produced by the forces. Then we come to clinical biomechanics. Biomechanics is the study of forces and their effect on living organisms. The clinical biomechanics is defined as the application of biomechanics to the treatment of patient, that is by orthopedic specialist and physiotherapist as well. Why does this pertain to us? Orthopedist or the physiotherapist also, even the occupational therapist and athletic trainers are healthy professionals who use biomechanical concepts to evaluate and treat the patients. Bioengineers and ergonomists and human factor specialists use biomechanical concepts to understand how individuals physically interact with their environment. The scope of clinical biomechanics is based on content areas of anatomy, mathematics, physics and clinical science. Really in orthopedics, mathematics means first of all the anatomy, then comes the physics and mathematics. The conglomeration will lead to very, very interesting biomechanical studies. Additional content areas include specific rehabilitation techniques, wheelchair designing, anthropology, specific tissue repair, surgical techniques and architecture. Does it exist in more than one field? Yes. The exercises are the sports medicine, the exercise and sport biomechanics, orthopedic biomechanics and occupational biomechanics. The kinesiology in biomechanics is the study of human movements is an important content area without biomechanics. Means without movement there is no life, because life is movement, movement is life. So every aspect of movement is considered on biomechanical science. The kinesiology involves also study of the skeletal system, including the major joint articulations, the major muscles, muscle groups that are prime movers during exercises. The main property in biomechanics is force, which can be defined as a push or a pull. A force that is applied externally to an object is expressed by us as a load. When the motion occurs, force is the factor that causes a mass to accelerate. So force is m into a. This is shown through the equation that force is mass into acceleration. I think all Newton, the exact definition of force, however, must consist of four things. That is the point of application, the direction of application, and the line of application, and the magnitude as well. I think it is the basic thing which we have read in physics, in Newton's law. All application of forces and motions on objects in biomechanics are subject to Newton's law of motion. Now, I can give some examples of does it exist in more than one field in sports biomechanics. Exercise and sports, say for example, hop, step and jumps. What should be the distance between this point, the pillar, so that you can jump more? That can be calculated easily if we take this into physical activities. The biomechanics in orthopedics, artificial limbs, joints and orthosis to improve functional movement and capability. Study of natural and artificial biological tissue. That once we discussed also this thing, that supposing say for example, means in a normal human being, the head of the femur is acting, is going on stress and strain and rotation, everything, for about 60 to 70 years, by the time it degenerates and painful. But if you have an artificial limb, the lifetime is 10 to 15 years. So there must be some intricacy in between, that what we are making and what is biologically present. Similarly, biomechanics does it in more than one field, that is the occupational biomechanics. Supposing you are driving a car, what should be the distance from the wheel to your chest so that you can have good look, simultaneously you do not have any strain on the spine. All these things are taken into consideration when we discuss with the biomechanics, and it is very, very applied to the activities of the human being. From a mechanical perspective, how do we generate and control our movements? That is also included in biomechanics. What mechanical and anatomical factors determine or limit movement outcomes? How can we make our movements better? Because the biomechanics is always for the betterment of movements and the mobility. Hundreds of articulations in the human body is there. Many injuries occur to these point structures. No two joints structurally are identical. Mobility sometimes have the distinct endpoints, that is elbow and knee. But in other cases, variable soft tissue properties and other factors also limit the range of movement. Some see stability as the joint's ability to restore dislocation. This is the liver system, what is occurring in the body, that first class liver. If the fulcrum is away from the power, the effect is quite different when the fulcrum is nearer to the power. In human being, almost all joints are of third grade, then third degree. First, when we stand, supposing we are standing on one leg, when we are testing for the tendon work, that is the liver of first order. But when we are working, any work you do, it is liver of third order. Because in human beings, whatever the movement so far for the activity is for precision movement. It is not the, but when you are a worker is working with the slopes, it is of liver of second order, because with least labor, he can have good outcome, the work. The mechanical analysis, if you take, supposing the bone is there, bone and muscle, if on the muscle side, you have got the extension, say for example, I am giving extension, if the forces are applied in this direction, it will affect first on the bone. But if the forces are applied in this direction, it will affect muscle, then comes the bone. Means you can tell that the forces when is applied when the bone is bare, opposite to the bone, then it will affect the bony area more than the reverse. That I am giving an example, that a person is driving a car. In that case, force is the most, means mass into acceleration, it is immaterial, that doesn't matter. In C5, C6, flexion is more than extension. In C6, C7, extension is more than flexion. And it is proved also, the area which is more in that direction, opposite direction movement will cause more injury. Means in C5, C6 level, extension causes more injury to the structures, and in C6, C7 level, flexion causes more injury to the structures. So during collision, there is hyperextension at C5, C6 leading to whiplash injury. So that is been calculated that why this is so, because of this. Because first of all, the bony extension injury, the bone is getting affected, so it goes to the spinal cord, so affection is more. Lap belt injury. So the point of the application of the belt is the fulcrum, that is this is the fulcrum, this is the force, and the in between is the L4 vertebra. Means it is of the fulcrum is here, power is here, work is here. So it is of second grade of liver. As a result, you get crushing of the vertebra. Therefore, lap belt injury, fulcrum at the point, force at the buckle, work is on the lumbar following, it is the second order of leads of liver. So reduction, as to conclude it, I can tell, but my intention of presenting this, in fact, in our center we are doing lot of, not lot of, biomechanical works. I teach also biomechanics in engineering college. Every batch of students and come, these postgraduates are coming. We are doing a lot of projects on this, and to find out
what could be the possible, the best way that we can have in active, in orthopedical outcome? Sir, we have done in Perthes disease also. We have calculated by our force application that it is the discrepancy between the adductor and the abductor which has led to all types of deformities. So there we have made a force these calculations that how it can be prevented, and we emphasize that if you do abduction laterally, means trochanteric advancement, it will give better result in active concentric reduction of the femoral epiphysis to the acetabulum than any other procedure so far is in vogue. That we have calculated. I mean, this way the biomechanical researches are going on. So therefore, biomechanics, what I coined it, that it is essential for understanding orthopedics. Thank you for listening this. This is not a paper. This is that I want to initiate the biomechanical ideas in the minds of my friends, juniors, and to have the interaction with my seniors. Thank you.
Any questions or suggestions to Dr. Sahu?
Yes, I require interaction. People should tell me.
If no, then we move on. Thank you, sir.
Thank you.
Is Dr. Samant here? He will talk about.
Okay. Respected chairpersons, my friends, my topic is arthroscopic rotator cuff repair. So in the span of nearly 2.5 years, we had total 34 patients, mean age being 61, male 20, female 14, and mostly dominant side. And we practiced both the single and the double row. And follow-up was minimum for 1 year. As you know, we classify the rotator cuff into A, B, C, like A for the articular side, B for the bursal side, and the C for the complete tear. If we talk of the partial tear, it is again 4 types, like your synovial irritation or furring, it's less than 1 centimeter, it's 2 for furring and cuff fiber failure less than 2, 3 for the fragmentation of cuff fibers but less than 3, and is either a flap tear or is more than 1 tendon. So these are the all partial tear classification. If we go for the complete tear, then it can be a complete small tear but it's like a puncture wound. Type 2 is moderate tear but less than 2, but there is no retraction. This is more important. 3 is the large tear, is usually 3 to 4, but some retraction is there. And lastly, the massive tear. Massive tear by definition is when it involves 2 tendons or else it is more than 5 centimeter and there is always retraction and scarring. So this sort of picture we get in all textbooks, like it can be crescent shape, it can be L or reverse shape, L or trapezoid, or the massive cuff, like more than 2 tendon or if it is retracted and more than 5 centimeter. So indication like your failure of conservative trigger, because all cuff we don't go for embark for surgery in every cuff tear. If it is acute big tear, young group and sporting people, and the night pain is very severe and patient is having some disability, then only you go for the surgery. And you all the routine classic tests like your knee test, Hawkins. Then you take test for the individual muscle like your subscap. This is a BR hug test for your subscap, belly press. Then again you have to test for the supra like your empty can test, Joe test. Then for the infra, and this is for the teres minor. So every muscle you have to test. This is a classic Joe test. So surgical test for steps as we follow for the partial lesion, that is the partial articular side tendon lesion, is you can go for the debridement only, or you can go for the single anchor fixation if you can make it complete, and we can fix it with single anchor. This is one MRI with your partial articular side here. I do all in lateral. This is a partial tear we see from the articular side, and once we see from the articular side the partial tear, we usually pass one spinal needle from the top so that we can locate from the top where was the tear was there. You can see we have already given one spinal needle. Then once we go on the bursal side, this is the CA ligament, and from the bursal side we can see where was the tear. Then we can locate whether how much tear is there. So when we talk of the complete tier, we usually is known as the smile sort of orientation of your portals. We sometimes create 5 or 6 portals. This is one MRI with complete tier. So you have to test the mobility of the cuff. Then sequentially you have to abrade the tissue, you have to use a bar. Then you punch the anchor. Then you can go with your special instruments, whether you can, these are the special anchors. Now we are using this anchor also all go for the, when we do the double row, we can use the footprint, relaying the suture. There are so many instruments are there. So this is the basic theory how we go with the complete cuff tier. If it is a small crescent, we can go like this. If it is a moderate crescent, we can go with this sort of tier. If it is a large U, then we can sometimes go for the margin convergence. Of this sort of L tier, we have to go with this margin, and you can fix like single row. This is one subscap tier. We are also repairing the subscap with arthroscopically. This is one tier, you can see is a big tier, more than 2 tendons, so we can classify like your massive tier. Then sequentially we abrade the great tuberosity. Then we can fix with the either with the single row and with the double row. So this is one technique. Just I went to Lafos. It is a very simple technique. You can take one 6-inch your stockinette, and if you give a 400-gram cotton inside, you don't have to buy the very handy or very costly sort of sling for your calf repair. If you give like that, it will abduct your arm for 30 degrees, and you can use this for a sling. It is a very, very innovative thing. It has been just taught by Lafos. And post-op protocol, you can go with the 3 phases like it's 6, 12, and more than 12 weeks, because you know for the calf it is the healing period and full recovery is around 9 months to 1 year. This you have to tell repeatedly to the patient. Milestones are like 6 weeks, you have to have more than 50% of your pre-op passive range of movement. 12 weeks you have to have the assisted equal to pre-op, and more than like your 6 months you have to have the active range of movement equal to pre-op. So follow-up is like that, and 3 monthly for up to 1 year. Scoring chart, we follow the UCLA score guideline. This is the guideline we all know. And you have to test how much power, how much active movement, how much external rotation, what sort of tendon was previously involved. And this was not very happy guy, because we could not get the full function at the end of 1 year. Even you can see there is some more restriction of movement at the end of 1 year. So result were like excellent to good in 29, fair and poor in 5. And if you go into the literature survey, you can see the Savoy, Wolf, Lowe and Burkhardt. You can see the Lafos paper, all that more than 94%, 95% you can have excellent to good result if you go with the arthroscopic technique. So advantages like that, if you go for the open method or the mini open technique, you cannot see the joint and diagnose the intra-articular lesion. Sometimes you can even miss the biceps paralogy. And you can treat faster by your open technique. You can have the better visualization, it is no matter, and the fixation, you can have the better fixation technique. So you can also treat the acromioclavicular problem, less deltoid injury, less pain, good physio, and excellent outcome. So disadvantage is only one. You have to, this learning curve of your arthroscopic cuff repair is at the end of the shoulder arthroscopy. So all arthroscopic rotator cuff repair gives excellent to good result if you even go with the excellent literature survey and compare it to this study, this follow-up was most studies. Thank you very much for your kind and patient hearing.
Any questions to Dr. Samanth?
What about cost?
Every cost is not that much, because you see now.
One anchor is, I am doing it.
Yeah.
One anchor is costing 12,000 rupees.
Yeah, if you wait, now you see, if you go with the foreign made implant, if you suppose you need the doubly loaded your anchor, then it is cost is around 7 to 12,000. If you go with a single row repair, the cost is, if you take all, suppose a big company, the foreign companies, then it is around 20,000. But now the
One anchor only?
no. How can you treat it with the one anchor? Minimum 2 anchor will be needed for any cuff repair, okay? Unless it is a pasta or a small lesion. If you need 2 anchor, the maximum cost will be around 20,000. But if you go with the Indian anchor, I am not naming, you can use them. Outside the hall we can discuss on that. The one anchor will cost around 5,000 with doubly loaded anchor. Those are really, believe me, it is very, very good.
Fiber wire?
Fiber with fiber, but preloaded, double loaded anchor. And if you go with only with the footprint, the Indian company, they have not devised. If you use the footprint, then the cost goes high. It's around 30,000 to 40,000 for each big calf tear. But most of the calf tear can be managed with 2 to 3 anchors.
Minimum double ankle will.
No, now there is a big debate. Because a big debate whether you go with the single row repair or the double row. Now it's like your double bundled ACL repair. It is again coming back to single bundle ACL. So again there was a lot of paper on double row rotator cuff repair, you know. Now again it is coming back to single row. Yeah.
How will you clinically differentiate? It is supraspinal repair, means there is a rupture in the supraspinal tendon or subscapula?
Or subscap. It is a very easy test. Just only remember 4 tests for 4 muscle. You remember the belly press and the bear hug for the subscap. You remember the job for 1 test for supraspinatus. You remember 90-degree abduction and external rotation, this is for infraspinatus, and 0-degree abduction and external rotation for your teres minor. So whole story, you don't have to remember 100 tests. And biceps only, belly press is for subscap.
What do you find there?
The thing is that you have to remember this. When you do the belly press, you have to remember very, very important point is that your elbow should be front of your coronal plane. It is not like that. Thoda nahi, it should be anterior to your coronal plane. Then remember, this wrist should be straight. This should be absolutely straight. And if the subscap is failed, tear is there, the elbow will go back and wrist will be like that. This is the typical picture of your subscap.
So instead of staying in the front,
You cannot sustain your elbow in front of your coronal
it
plane.
will go back.
Another one very, very easy test that has been devised by Barkart, because I was a fellow of him. The Barkart, he usually tests with your beer hug. Beer hug means you have to test the other shoulder or the acromioclavicular joint, spread your fingers and ask the patient to press on the shoulder and you try to lift it. If you can't lift it, subscap is intact. If you can lift it, subscap is gone. So remember only 4 tests. One is your job, supra, job test, empty can test. Remember that this arm should be at 30 degree of the scapular plane, 90 degree abduction. The thumb should be pointing down. That means the empty can sign. And if you ask the patient to lift the arm, if we can't, then supra is gone.
You give a resistance or just like that?
No, just resistance you have to. Otherwise, how you because your deltoid will go up, na? You have to, because to negate the function of the deltoid, you are putting all this. Because the scapula is 30 degree front, so it should be at the 30 degree plane of your coronal plane. So 4 tests you remember for 4 muscle. And biceps, you know, you do either the speed or the Yergason or the O'Brien.